So just before the break, we talked about shared decision making, and just before we get into deprescribing, I wanted to share one other tool or resource with you that I think you might find useful to help support shared decision making. Because when giving a patient, their caregiver or family members good quality information and taking the opportunity to have that back and forth, that takes time. And it is an investment of time up front that will definitely pay dividends down the line. So one of the tools you can use is called a decision aid. And a decision aid is something that will increase a patient's awareness and understanding of treatment options and possible outcomes. Decision aids are available online, in print, or as videos. They can efficiently help patients absorb relevant clinical information and aid them in developing and communicating informed preferences. And we know when we've studied the use of decision aids with patients, the result of their use is that patients have increased knowledge. They may have a more accurate risk perception. It'll increase the number of decisions consistent with patient values. It will decrease the level of internal decisional conflict for patients, and fewer patients remaining passive or undecided. So ideally, you'll hear less, "I don't know, what would you do? What do you think I should do?" So again, empowering those patients with the information they need to make a good decision. So I've got on the slide here a link to the mayoclinic.org shared decisions. And on this particular website, you will find succinct, easy to use tools that provide graphic displays of both benefits and harms of different options organized around concerns that are important to patients. So I have two examples that I'll show you. The first one that you'll see here is osteoporosis and oral bisphosphonates. And what you see in the graphical depiction is on the top, without medication. So what is the risk of a fracture if you're not taking a bisphosphonate? And below, what is the risk of a fracture if you are taking a bisphosphonate? And then on the right-hand side, you'll see other considerations that are important for patients to consider, such as what it takes to adequately get this medication into your body. You take it once a week, perhaps once a month. It's got to be on an empty stomach. You have to stay upright for about 30 minutes. And then what are the possible harms? For example, what are some of the side effects? Osteonecrosis of the jaw might be something that a patient could find if they were to Google this particular topic, and it puts it into context for them. So fewer than 1 in 10,000 folks may experience osteonecrosis of the jaw, for example. And then it also looks at cost. So patients are provided with all the information they need. This is something you could provide them and they could go home and think about, and then they could come back and have that discussion with you. The second tool that I will show you here, the other decision aid, is around statins for primary prevention. There's not a lot of debate whether or not a statin should be used for secondary prevention, because we know there's a great benefit there. But if they haven't had a heart attack, what are the odds that a statin will prevent that first heart attack? Well, that's what the first graph on top shows. And then beneath, it also shows what their odds are if they were to take a statin. On the right-hand side, there's the risks and concerns associated with statin use. And then finally, the third section is to prompt them whether or not they think they'd like to try this particular medication. So great tools available for free from the website that you can download and provide to your patients to help inform those discussions and aid in shared decision making. So let's move on to another concept in optimizing medications in older adults, and that's deprescribing. So what is deprescribing and why do we do it? Well, it's all about really decreasing polypharmacy. And when we decrease the use of medications, we may see a decrease in the risk of adverse events, a decrease in the risk of drug interactions, decreased pill burden, which is often a complaint of patients taking many medications, and of course, decreased medications costs, something very important to someone who is on a fixed income. But the challenge is that in some circumstances, the only way to know whether or not to stop a medication is to actually stop it and see what happens. Now, that might not be something you want to do with every medication. So here's two considerations when deciding whether or not to just stop a medication. So we can group them. So the first group of medications are those that keep the patient well and improve their day-to-day quality of life. For example, analgesics, they're painkillers, or maybe they're thyroid pills, or perhaps they're anti-anginals for that chest pain. In some cases, if these medicines were stopped, the patient might become ill or unable to function. However, Some medications may not be able to be stopped, but decreased or stepped down and maybe eventually stopped or used as needed. And a great example of a medication that can often be bumped to as needed use after some time is a proton pump inhibitor, or those medications that we use to suppress acid, like rabeprazole or pantoprazole. Great medication that's often left on and not reevaluated as often as it should be. Should probably be reevaluated once a year. We can often recommend a patient sort of back off and just use it as needed. The second category of medications, and the ones that are a bit more challenging to see cause and effect, are those that are used for the prevention of illness in the future. So for example, those statin or those cholesterol-lowering medications, aspirin to prevent a stroke, warfarin to prevent a clot, or bisphosphonates to prevent a fracture. So a decision about whether or not to stop these particular medications should include that consideration of what is the risk and what is the benefit for this particular individual in front of you. Again, that time to benefit comes into play here. How much time do you need to be on this medication before you can potentially benefit from it? And then of course linked to that is what is the life expectancy of that particular individual. So that's where those decision aids certainly come in handy. So other deprescribing considerations when you're thinking, okay, should this medication be stopped, is what does the patient think? What do they want? What are their goals? The next thing to consider is clinical indication and benefit. Why is this individual taking this medication, and then is it actually working? Appropriateness. Is this the right or the best medication for this individual? Duration of use. Do they still need it? Again, going back to those PPIs like rabeprazole, do you still need that medication, or can we start to step it down? Adherence. Are they even taking it anyway? Just because you're prescribing it, just because they're maybe picking it up from the pharmacy, doesn't mean it's actually going into the body. And then of course, on the lookout for those prescribing cascades causing side effects and then getting treated as a new condition instead of addressing that side effect and resolving that. So again, I'll pass it back to Dr. Martens to get his thought on deprescribing.
It's actually kind of fun, but it's also kind of scary. And I must confess, I am a little bit of a hypocrite when it comes to this. I don't do it nearly as often as I can, but it is very gratifying when you are able to stop things. Patients often feel better. Even if they're physically not much different, they feel better in the fact that, hey, I'm on fewer pills, I must be healthier. Okay, and that's not a bad feeling to have. You do need a motivated patient and or family in this situation. It's generally successful, and some of the studies that I saw rated it as over 95% of the time it works without a problem. And for some of those drugs like the PPIs where you're taking it for a symptomatic problem, the patient can tell you if they need it. Well, try it every other day. Oh, try it twice a week. Oh, just take it if you need it, okay? And they're able to tell you whether or not that's working for them or not. Most of these things do not need to be done immediately or fast. You can go slow, take your time, talk to people, discuss it with them, and see whether or not that this is something that they want to do. And of course, review the results. Are they happy with it? Do they feel better without these drugs? And if that's the case, hey, it's a win-win situation. They're happy, I'm happy, no problem. Now, the one problem that I have run into is a non-motivated patient, and there are some out there. It's not going to work, okay? When I first started practice, I was amazed how many of these 85-year-old ladies would be coming in from north of town. It didn't matter if you forgot to give them their blood pressure pills, their diabetic medications, whatever. Heaven help you if you forgot their little blue sleeping pill, okay? And that sometimes is the hardest one to get people off of, and they need to be willing to try it before it's going to be successful. Vitamins. Also an issue, and it depends on the person's belief system as to whether or not this is an important thing for them to try off of. Again, it requires discussion. Is this something they're willing to try? I had a patient quite a few years ago who was on enough medications to start his own pharmacy, and really it bothered me. I thought it was far too many. I wanted to get him off of it, wasn't sure where to start, yada yada. Sent him to Dr. Tom Wilson, who's I think retired now. And the afternoon, right after the visit, I got a phone call from the wife who triumphantly told me, we convinced him that he needed every pill that he was on. And I thought, yeah, you missed the point, okay? I'm waiting for that letter back from Dr. Wilson, and again, what he said is, the patient isn't willing to stop these pills. There's no point. He seems to be okay with them at this time, but until he's wanting to decrease his pill load, it's not going to be successful. So you got to have buy-in by the person, the patient, and the family in some cases as well. So
I think it's important to acknowledge too, when deprescribing and maybe stopping a medication, some medications require tapering.
yes.
If it took time to get up to that dose, it's going to take time to get off that medication. The only exception to that rule is if the individual is experiencing a very significant adverse event. But folks can experience withdrawal symptoms if we go too quickly. For example, if we were to get rid of that nice little blue sleeping pill, it's very common to have rebound insomnia. And it's truly not insomnia that now we think we need the medication for, but rather if we educate about this probably 7 days duration of bad sleep and then it will get better, will help us get that individual out of that Zopiclone trap, if you will, of trying to come off it, getting rebound insomnia, going back on, trying to come off, getting rebound insomnia. And the same phenomena occurs with those PPIs. Again, pantoprazole, rapeprazole, good examples. If you quote unquote cold turkey them or stop them abruptly, you will get that rebound hypersecretion, and the symptoms will come back and create the illusion, if you will, that the GERD or those symptoms still exist. So a great medication to slowly decrease and even maybe go every other day and down to as needed. One of the RxFiles resources is the Jerry RxFiles, which has an entire section of which medications require tapering and as well how to approach that tapering. There's not a lot of great evidence. It's often a bit of trial and error in how well that individual you're treating tolerates those changes. So back to deprescribing, where to start? Well, I say go for the low-hanging fruit. It's always easy. So in our particular case, we have an individual who's on metformin, great evidence for cardiovascular outcomes. Ramipril's got a lot of evidence. Atorvastatin, sure, she's got maybe high cholesterol, we're not sure. Sertraline, we have depression. But what's that hanging down low there? Docusate. In my world, Docusate is a no-brainer. Pluck that apple right off the tree and throw it over your shoulder, if you will. And I like to tell everyone, don't. No Docusate. Why? Well, Docusate appears to be no more effective than placebo for increasing stool frequency or softening stool consistency. And everyone's taking it because they're constipated, generally my experience. So it does not appear to lessen symptoms associated with constipation. So for example, abdominal cramps, or affect perceptions associated with completeness of or difficulties with stool evacuation. And if you're looking for more detail, more evidence, because you're trying to maybe convince a colleague or start an initiative in your particular work setting, the cadith.ca website has all the information you need to show others that maybe Docusate or Colase isn't all that it's cracked up to be. A few other tips to keep your eyes open for when reassessing medications in older adults. Triple whammy is one. So what is a triple whammy? It's the risk of acute kidney injury when someone on an ACE, like ramipril, or an ARB, for example, candesartan, is combined with a diuretic and an anti-inflammatory. So who would ever take this triple combo? Well, someone who has high blood pressure, someone who has heart failure, or maybe renal disease, and who also has arthritis or mild to moderate pain. And generally, as older adults age, they experience arthritis or aches and pains and often need something to treat that mild pain. So let's think back to our patient, our 82-year-old female who has hypertension and osteoarthritis, and based on her renal function, is stage 3 chronic kidney disease. So what happens? And this is the point where you might want to hold on to your pharmacodynamic hats here, because this is going to get a little technical. So ACEs and ARBs will reduce the glomerular filtration pressure via vasodilation of the efferent arteriole. So that big vessel that comes out of the bottom of the kidney gets opened. And then diuretics reduce the blood flow into the kidney by intravascular volume depletion, right? They're getting rid of that fluid from your body. That's why we're peeing more. That's what a diuretic does. So now we've got an open out valve, less fluid coming through the kidney, and now we're going to throw on an NSAID. And that will reduce blood flow to the glomerulus by inhibiting the production of vasodilating prostaglandins. So what happens here? I know this is getting really technical. It's lots of fun. This will be on the test later. So when renal perfusion is impaired, so we're not getting the perfusion we need because we're taking a diuretic, or maybe we're dehydrated. That's going to be an important point later as well. The whole renin system, so the renin secretion and that angiotensin II production is triggered. So when angiotensin II then works to improve, tries to get that blood flow back up in that kidney by constricting that out valve, that efferent arteriole, to help maintain that pressure in the kidney. Well, then prostaglandins come into play. And their synthesis is another compensatory mechanism where they dilate that in vessel to help increase blood flow into the kidney. But now we've started an ACE or an ARB, and we have an NSAID, and we're on a diuretic, there's less fluid. All those compensation mechanisms are basically blocked. So our kidney is not perfused as well, and we can experience acute kidney damage. And when we're already at a pretty low kidney function, 32 mils per minute in this particular individual, we don't have too far to go, and we want to watch out for our kidney health. So anti-inflammatories such as ibuprofen and naproxen, available as Advil, Motrin, or Aleve, are over the counter. And anyone can go and pluck it off the shelf. So this is, again, pulling back to why that brown bag assessment is so important, as well as educating our patients who might be taking those diuretics, ACEs, ARBs, about the risks of over-the-counter medications. And while we probably can't tell them everything we need to know, we can certainly encourage that they're always asking that pharmacist to assess their over-the-counter choice to ensure it's safe and appropriate for them. So be on the lookout for the triple whammy. Next, Zopiclone. New warning from Health Canada. Just came out November 2014, so not too new. But they are recommending that if you're going to start this medication in anyone, it should be started at 3.75. So that's half of that little blue pill, half of the 7.5. And that the lowest effective dose should be used for everyone who's going to use it. But if you have someone who is elderly, or maybe they have hepatic or renal impairment, or those currently being treated with other potential interacting medications, their dose should not exceed 5 milligrams. They also go on to state that if anyone is taking Zopiclone, that they should wait for at least 12 hours after dosing before driving or engaging in other activities requiring full mental alertness, especially older adults, and for those who are taking as high as 7.5 milligrams. So if you think back to the patient population that you work with, that you serve every day, are they on Zopiclone? And how much are they on? How long have they been on it? Do they still really need it? And we know there's lots of risks associated with this class of medication, even if they're not driving, just falls, cognitive impairment. So it's a great target to go after to start reducing that dose and educating that patient or their family or their caregivers about the risks and benefits, and preparing them that if they are going to come off of it, they may experience approximately 1 week of a bit of rebound insomnia, but if they fight their way through it, that's one less pill they have to take, and also a medication that's not often covered through the drug plans, so less of a cost. Another concern that we're worried about in our particular patient is the use of her sertraline, because SSRIs have been associated with syndrome of inappropriate antidiuretic hormone, or SIADH, which is hyponatremia, so our salt goes down. So risk factors for this are, of course, SSRI use, diuretic use, because we're going to get volume depletion. So if she's still on that hydrochlorothiazide, we're concerned. And then age, she's 82. And then again, there's that volume depletion. What happens if she's not feeling well and she gets a bit dehydrated? We're definitely concerned about the sodium level. So while SSRIs are certainly beneficial for individuals maybe with anxiety or depression, it's very important to monitor sodium, especially when you initiate or change a dose, whether that's up or down. And the population who's at greatest risk is anyone who has experienced the hyponatremia, so less than 130 within the last 3 months. So just something else to be aware of. Throw that on the radar. But SSRIs are also associated with GI bleeds. And again, there's many risk factors here to consider. Of course, SSRI use, and then NSAIDs. So is our individual with her osteoarthritis actually picking up that naproxen off the shelf at the pharmacy? And then age again. The older we get, the greater the risk of a GI bleed. So we know that SSRIs are associated with a modest increase in the risk of the upper GI bleed, so in the stomach. And this risk is significantly elevated when SSRI medications are used in combo with NSAIDs. So a low-dose aspirin every day is considered an anti-inflammatory. And then if we throw on an over-the-counter Aleve for that osteoarthritis pain, the risk certainly increases significantly. And if you're wondering how SSRIs play a role in GI bleeds, it's because serotonin is required for platelet aggregation, and the effect of SSRIs on that platelet aggregation appears to be dose dependent. So if we ensure someone's on the lowest effective dose, we're certainly doing our best to negate that risk as best we can. But don't forget, it's always about risk versus benefit. So an individual with depression will certainly benefit from the treatment of their depression with an SSRI to improve their quality of life. And if they're using ASA for secondary stroke prevention, that's certainly an opportunity for benefit. If they're using it for primary prevention, however, you may want to revisit the use of that medication and perhaps discontinue it. So moving on to a controversial topic, that is metformin and renal function. As Dr. Martens alluded to earlier, metformin is really the only drug with great outcome evidence, but we're concerned about its use with folks with decreased kidney function. So when do we stop it? When do we just decrease the dose? And when do we keep going? Well, first, let's think about what we know about metformin. Well, it's almost always the first line drug of choice, except possibly for lean, frail older adults, and again, possibly, and that's only because for these individuals, their principal metabolic defect is impairment in glucose-induced insulin secretion, so they might need those drugs that stimulate the insulin secretion or squeeze the pancreas to get that insulin out, such as a sulfonylurea like glycoside. We have no RCTs using metformin in the elderly, and RCTs are sort of our gold standard of evidence, although we've got many years of clinical experience that suggest it works very well. It has a very minimal risk of hypoglycemia. However, very important, it must be initiated with a low dose and titrated up to minimize GI upset. So a few things to consider here. Remember back to time to benefit. We want to get your blood sugars down, but we've got 5 years before that microvascular complications start to kick in. So there's no need to get you at a target metformin dose in a week. And this particular medication can really irritate the GI tract, and often we see patients complain of diarrhea, and sometimes debilitating diarrhea. But we want them on this drug because it has great outcome evidence. So start low and go slow. A quarter of a 500 milligram tablet, as you tolerate it, increasing it by that little bit, although it may be crumbs, is worth it if it means that patient's going to buy into that treatment and stay on it. Perhaps you've encountered that patient who was started on 500 BID, had wicked diarrhea, and refuses to ever try it again. That's a concern, because what are the next options? And often those other options will increase their risk of hypoglycemia. So metformin, start low, go slow, get it on board. And it's important to know that it may be used in individuals with decreased but stable renal function. So we don't have to avoid it in those with decreased renal function, but we want to ensure it's stable, and we want to adjust that dose appropriately. So other things we know about metformin, it's a great drug. It's very useful, And if you have an individual who is on insulin, it can actually decrease their insulin requirements. And it's cheap, it's inexpensive, very accessible medication as a result. Doesn't cause weight gain. Some agents can, especially insulin. And again, the big kicker, it's actually shown to reduce cardiovascular mortality rates in type 2 diabetes. And if you're wondering why we've emphasized that point, sometimes it's easy to get lost in the evidence looking at surrogate markers versus outcomes. For example, a surrogate marker in diabetes is blood sugar. A1C, fasting glucose, it's a marker for sugars, but what do we really care about? Cardiovascular outcomes, death. Same thing with cholesterol. Your surrogate markers are your LDL cholesterol. Your big outcomes that you're worried about, heart attack, stroke. So sometimes either medication, especially many of the new diabetes medications, don't have outcome data. It doesn't mean they don't prevent death. They've never been shown to do it. No one's ever done a study. So we always want to ensure we're using the medications that have been proven to provide those outcomes first if we can. So what about metformin in the kidneys? We need to adjust. And the guidelines would state, remember, guidelines, just a guideline, both the Canadian and the Americans, to avoid metformin if a creatinine clearance is less than 30 due to the risk of lactic acidosis. That's our big concern. However, I would dare say it's rational to have some flexibility with this suggested cutoff. Again, because metformin has so many benefits. So let's look further into this kidney issue. So given the outcome benefits seen with metformin and the rare and controversial association with lactic acidosis, it is sometimes used cautiously in individuals with that lower renal function. And you need to think about what's the alternative to metformin. So other medications have risks, including hypoglycemia, as I alluded to, right? Sulfonylureas, perhaps edema or weight gain, or heart failure and fractures with medications like pioglitazone and rosiglitazone. And often we don't have a lot of evidence for their benefit, and definitely not a lot of information about safety and, again, evidence for benefit in this population. And it's been suggested that the risk of death as a result of a sulfonylurea or even insulin that causes hypoglycemia in someone with chronic kidney disease, and we know many older adults have decreased renal function, is likely to be greater than the risk of death due to metformin-associated lactic acidosis. So on this next chart, you'll see another excerpt from one of the RxFiles resources where we talk about if this is your kidney function on the left, here's your recommended dose also on the left-hand column, and how often you want to monitor it on the right-hand side. So when we get into a creatinine clearance of less than 30, we say you may want to avoid, but I'm going to give that a bit more context. But you definitely want to hold metformin when you are dealing with someone with an acute exacerbation of heart failure or renal failure, right? We're seeing that fluid depletion perhaps, and acute gastrointestinal illness. So if someone's vomiting, nausea, diarrhea, because they're getting, again, dehydration and or volume depletion, and this is where your risk of lactic acidosis is increased. So what's the deal with lactic acidosis? Well, metformin-induced lactic acidosis is rare, about 1 to 9 cases per 100,000 patient years. And really, we're not sure that metformin causes it, but rather it's coincidental. It's a link, again, rather than causal. But there are many risk factors for lactic acidosis, and any condition that causes hypoxemia is definitely going to increase your risk. So these are the folks you want to take a closer look at who may be taking metformin. So anyone with acute cardiovascular condition, like heart failure, an acute renal condition, so perhaps they're getting that contrast media for diagnostic purposes, acute hepatic condition, perhaps they have severe hepatic dysfunction, if they're in respiratory failure, sepsis, or hypovolemia. So if the question is, metformin's never been proven to cause lactic acidosis, and we think it's more of a coincidence than a cause, what's all the fuss about? Well, metformin used to have a sibling on the market called fenformin, and it was actually pulled from the market in the late 1970s because it was proven to cause lactic acidosis. And as a result, folks were very cautious with metformin because they feared that it may also cause lactic acidosis. And lactic acidosis isn't something to take lightly. It is definitely a life-threatening event, and we see a 40 to 50% death rate with it. And its onset is subtle, and it's accompanied by very non-specific symptoms, so it can sneak up on you, if you will. So malaise, myalgia, respiratory distress, increased solemnness, and abdominal distress. Of course, none of those symptoms scream lactic acidosis, very vague. You can go to your labs and look for low pH, an increased anion gap, and elevated blood lactate as well. So we know metformin can offer many benefits to our patients, even if they have reduced renal functions. But we've got to be careful and be safe rather than sorry. So the Canadian Diabetes Association put out this nice little mnemonic to remember which drugs you might want to hold in acute GI illness, again, nausea, vomiting, diarrhea, because of the risk of dehydration and fluid depletion, that you can give to your patients to inform them of what they should stop taking in the event that they're ill. So you see Sadman, S, those sulfonylureas. Stop taking them, and that's because we're worried for hypoglycemia. ACE inhibitors, so your Ramipril, hold those when you're feeling ill because we're worried about your kidney function. Diuretics, hold those when you're not feeling well, again, because of kidney function. Metformin, we want to hold that not because we're worried about your kidney function, but rather, again, the potential risk for lactic acidosis. And then we see our ARBs, and finally our anti-inflammatories, including Celebrex in there. So these are the ones that you can simply instruct your patients that if they're on them, you're not feeling well, don't take them. And none of these medications require tapering. They can abruptly stop them. And when those symptoms resolve and they're feeling better, they can resume those medications. And on the slide here, you'll see a handout available from the CDA website where you can actually write in the names of the medications that your patient is actually taking and hand that to them so they can take that home and have no questions if they need to come back and see you. Because we know often healthcare professionals can be a bit of a challenge to access, especially if it's a physician who's quite busy. So it's nice to have this and they can sort of take charge of their own health and ensure that they minimize the risk of harm. So now it's time for a little musical interlude, and I'd like to share this video with you because I think it's a great summary of all the concepts we've talked about today, and I'm going to apologize in advance for you humming this song for the rest of the day. So I think we'll go on to the video now. Excellent. So Dr. James McCormick is the brilliant mind behind that video, and we've included the link to it on YouTube if you'd like to share it with your colleagues.